Dr. Shana McCormack is an attending physician in the Division of Endocrinology and Diabetes at Children's Hospital of Philadelphia and in the Healthy Weight Program. She cares for patients with endocrine dysfunction related to primary forms of mitochondrial disease. Her areas of interest include endocrine dysfunction and mitochondrial disease. Thank you very much.
Is the microphone working for you guys? Awesome, thank you. If that changes, just wave. Well, I really appreciate everybody staying until the end, and I appreciate you coming to listen to the talk. Just as the introduction mentioned, my name's Shana. I'm an endocrinologist from the Children's Hospital of Philadelphia. And so you will be asking, why am I giving the talk about endocrine dysfunction in adults if I'm a pediatric endocrinologist? Well, there's several reasons. The first reason is that they asked me to, and UMDF is awesome, and so I do what I'm asked. We also get training in the care of adults with endocrine disorders as part of our fellowship, so that is something that we have had clinical experience with. I care for adults with mitochondrial disorders in the context of our research protocols, also sometimes in the context of clinical visits, because at CHOP, our colleagues in metabolism do care for adult patients, so sometimes I see them as well. As my clinical practice has kind of filled with more pediatric patients, now I collaborate with our colleagues at Penn Metabolic Medicine on the adult side to care for adults with mitochondrial disease and endocrine dysfunction. So I'm hopeful that within a year or two they will have accumulated enough patients and experience that they'll be sharing their more refined experience in the talk. So that's the introduction. This is how I think about my assignment for today, and really my assignment for my research as well. I'm an endocrinologist, particularly interested in neuroendocrinology. So I focus on how hormones come together with how the mitochondria work, as well as the environment broadly defined to produce health. So this is what I'm going to talk about today, a brief outline. So this figure is from a terrific review by a group in the UK on all of the different endocrine problems that can happen in mitochondrial disorders. I'm happy to share the paper with you or with your usual endocrinologist. Really, if you can think of a hormone, it can be affected by a mitochondrial problem. But we're really just going to go through each hormone system today and give you some background. So my goal is to really provide you with enough background that you can identify what the important questions are to ask when you see your usual metabolic physician or your usual endocrinologist. There's a huge caveat here. Everything I present, I think if there's kind of one rule in the care of patients with mitochondrial disease, is that everyone is different. So if we each had $1 for the number of times that heterogeneity was mentioned in the research talks, we'd all be rich, right? Like there are rules, but a lot of people don't follow the textbook. So just remember that as I speak. I'm going to try to highlight, this is an addition based on some feedback that I thought was really helpful, some web resources that I feel like have really helpful information as I go through the talk. So endocrine axis by endocrine axis will go low and high blood sugars. This is what I usually get called about first when they happen. Stress and adrenal function, calcium and bone, thyroid, sex steroids. Growth hormone is not just for children, so we'll talk about that. Lipids, and also excess weight gain. I am not going to cover insufficient weight gain because usually that gets handled by other folks, but I'm asked increasingly about that, so I'm going to talk about it a little bit. And I'm also going to, because I can't resist, share a little bit about our research, but not a lot, I promise. So NAMDC, you guys have heard a lot about NAMDC, about UMDF, and the value of registries. So this is a work in progress by Iman Al-Ghadi. She's a pediatric resident who's interested in going into endocrinology. Yeah, we're not talking about fertility either, but we are talking about sex steroids. We'll get to that. she is looking at the NAMDC data and looking at the prevalence and impact of endocrine problems. So these results are in the works. There's a manuscript in preparation, but I put this chart up for two reasons. One is I'm going to tell you what it shows, but second, when I first gave a talk about endocrine problems and mitochondrial disease at UMDF several years ago now, I didn't have the benefit of this terrific resource. So all of your decisions, many of you will decide to participate in one of these registries and share your experience and your data really helps us and also helps us recruit trainees and have something to teach them about the care of folks. So I really appreciate that. So with respect to diabetes, you may not be able to read from where you're sitting, but by age 21 to 24, the prevalence of diabetes in the NAMDC cohort goes from 16% up to around a third in older adults. So diabetes is a really significant problem. We have a second category here, atypical growth and sexual maturation. We put all of that together because it's all related. So people who didn't grow well as children, who maybe had different than typical pubertal development, all of that has lifelong implications for health. Children report that in high proportion, but adults report it as well. Hypothyroidism, actually this isn't as prevalent as I thought it might be, so this is another interesting piece of education. More common in women, similar to the general population. In one group here around 10%, and in the older group around 20%, so it seems to increase with age. Yeah?
I'm sorry to interrupt, but when you mentioned diabetes, I don't know if you're talking about type 1 or type 2.
I am so glad you asked that very good question, because I get that all the time. Can I ask you to table until the diabetes section, and then if it's not sufficiently answered, you revisit? But for the question where people were asked, people just asked diabetes. And it was like NOS, yep. So when they're asked, then there's some things that are filled in detail, but some things that are not. So this is, what your question is a good one. It brings to bear, the NAMDC, the data gathering is like a first pass, right? We're learning a lot from, okay, you kind of have to start somewhere, and you ask people a lot of questions, and then you get back these data, and then if you're me or you, and you're like, but what was their diabetes like, and who was on insulin, and what were their A1Cs? And we're like, well, we didn't collect that. Like, we didn't know at the time that that's what you're interested in. But now we know this impacts a lot of people, so it's probably worth collecting more granular data. However, if you never knew this, or if you asked all those detailed questions but then found diabetes affected very few people, then that wouldn't have been worth your time. So this is a bit of an iterative process. That's a great question. And types of diabetes are important. So these are the questions that were asked specifically. These are other categories of endocrine problems that were just reported. So it's not that every single person was asked whether or not they had adrenal insufficiency or early puberty or osteoporosis, but people reported it. So those were prevalent as well. I'm drawing your attention to another paper that we published recently that's related to this talk on hospitalizations for individuals with mitochondrial disease. We wrote this paper because I think it's important to quantify the burden of this condition in lots of ways to demonstrate the need for research and advocacy. But for me, it was interesting because, sorry, this got cut off. There are a lot of endocrine and metabolic problems represented in individuals who are hospitalized. So what this figure shows you, every single dot is a kind of comorbidity, a kind of additional diagnosis besides mitochondrial disease, so another health problem. So every time someone comes in the hospital, we list all the problems that they have. So mitochondrial disease could be one, but then diabetes could be another, or heart failure could be another. And then there are databases that compile all of this information. So we took a national database that looked at 2,000 hospitalizations for adults with mitochondrial disease. And then on the y-axis here is how many times a particular comorbidity or additional diagnosis was mentioned. And of course, I go right to the red because I'm an endocrinologist and I want the red endocrine metabolic diagnoses. So lots of cholesterol, lipid problems, dehydration, potassium problems, malnutrition, acidosis, hypothyroidism falls in here, obesity again, problems with sodium levels, and then of course insulin use. So these problems are a little different than the ones that come up in the NAMDC because they're more relevant for the hospitalized patient. All right, so on to each endocrine axis. So low and high blood sugars. This is a figure that shows how I have come to think about mitochondrial disease and blood sugar. So here is nutrient availability, right? So this is where there's lots of nutrition around, and here's where there's not a lot. And then on here is the blood sugar. I think of individuals without mitochondrial disease or healthy people as having this wide range of nutrient states or conditions where they're able to maintain a normal blood sugar. But for folks with mitochondrial disorders, that safe range shrinks. So it's much easier for them to fall into either low or into high. So one thing I'll tell you that when I hear in clinic, I'm surprised to learn that folks find it satisfying is that I say, well, I see people with high blood sugar and I see people with low blood sugar, and often those are the same people. And that resonates with a lot of people's experience, that their blood, in other conditions, sometimes it's all high and sometimes it's all low, but in mitochondrial disorders, often it's both. And I think that it's in part because all of the systems that help keep that blood sugar in a good range don't work in a typical way. So low blood sugar is what you do. Hypoglycemia is a really common problem. This is a poster the residents have in the endocrine workroom, which says keep calm and push T10, because often that's the right decision and that's the right thing to do, is dextrose containing IV fluids if the blood sugar is acutely low and the person is having symptoms. When giving a talk to this group, I want to emphasize a couple of things that don't always happen in the setting of mitochondrial disease patients. One is to look for specific treatable causes. So in my experience, sometimes hypoglycemia is attributed to the mitochondrial disorder, which is potentially reasonable to do, but without looking for other things like cortisol deficiency or growth hormone deficiency or too much insulin or malnutrition. So mitochondrial disease, we heard this morning about all sorts of wonderful medicines that are in development for specific therapy of that disorder. So those medicines are in the pipeline. Until they're approved, there are still medicines that can treat symptoms, and we should look for treatable causes of hypoglycemia before assigning them to mitochondrial disease. Keeping the blood sugar in a typical range is a reasonable proposition. Most people feel better with a normal blood sugar. And ideally having an emergency plan in place and the letter in place before illness. So folks having an emergency letter of what to do if they're hypoglycemic, particularly if they've been hypoglycemic in the past and they've learned from that experience what treatment they need to bring the blood sugar up. Having that emergency letter in place is something we make sure all of our patients do. So that's low. So this is endocrinology like Zoom, right? Like this is a lot's happening. So I know that this gets recorded and folks go through it. And there's so much more to unpack in each of these slides, but I was interested in going through all of them rather than any one in detail. So thanks for your patience there. So that was low blood sugar. Now we're talking about high blood sugar. Switch gears to diabetes. So diabetes occurs commonly, as you saw from those NAMDC numbers, in the setting of mitochondrial disease. And it can happen for two reasons. Insulin resistance and insulin deficiency. So insulin resistance happens so insulin is that main hormone that helps control the blood sugar. Insulin resistance happens when the insulin doesn't work as well in the body. That's been studied and been shown. We've looked at that, and MILOS is one example where it's been looked at in more detail, where insulin resistance can happen. So even if you're making insulin, it doesn't work as well, and so the blood sugar can creep up. The other thing that can happen is insulin deficiency. So the pancreatic beta cell, the pancreas is located right here, is what makes insulin. And in some mitochondrial problems, it doesn't make insulin quite as well. And why does that happen? And this is where the person's great question about type 1 and type 2 comes up. This is different than either type 1 or type 2 per se, because it's a bioenergetic problem. So I'm not going through this figure in detail, but it helps me make a point that surprises people, and so I wanted to share it with you. Is the reason that the beta cells don't work in mitochondrial disease as well as we think, at least one reason, is that insulin is secreted, this is insulin right here, is put out of the beta cell, and people know that insulin is produced in response to glucose, right? Like everybody knows that, you have a lot of glucose, your pancreas puts out insulin to control it. But it actually, the pancreatic beta cell doesn't respond to glucose directly, it responds to ATP. So you guys have been at this meeting for however many days, you know what ATP is, but in case you don't, ATP is the energy currency of the cell. And ATP is made by the mitochondria. So in order for insulin to be spit out of the beta cell, glucose, which is this, you can't see it, but trust me, glucose has to come in here, be processed in the mitochondria into ATP for these events to happen and insulin to be put out. So it really is a bioenergetic problem that the insulin doesn't respond to this glucose because this is not producing ATP. So that's mitochondrial diabetes. No problem, right? And what do we do for diabetes in the setting of mitochondrial disorders? Well, first thing, if you don't have it yet, you should be aware of the increased risk because we really want to make sure that people with diabetes are diagnosed early so they don't get sick. So especially for our younger individuals, being aware that excess urination, excess thirst, or really just any change from status quo could reflect a problem with blood sugar. Screening, we are working on guidelines that are going to be published imminently. For many mitochondrial disorders, if not most, a hemoglobin A1C is an easy blood test to do to screen for diabetes. You could speak with your metabolic doctor if you undergo routine or annual surveillance testing for diabetes. To my mind, it's a straightforward thing to do to see kind of where you're starting and how you're progressing. With respect to managing diabetes, we have a saying in medicine that management is measurement. Like we address what we are able to measure. So if you have diabetes or are on your way to having diabetes, learning to measure blood sugar and ketones, particularly in the setting of illness, is important. Ketones I'll get to in a minute, but this reminds me that people can screen negative for diabetes with mitochondrial disorders and develop very high blood sugars only when they're sick and require insulin only when they're sick, and then leave the hospital, and in some cases relatively quickly come off insulin and not need it again until they're sick again. That happens sometimes, and not infrequently actually. So being aware that when people are sick that checking a blood sugar is a reasonable idea because it can be high and it can sometimes be low is good to know. Ketones are something some people are not familiar with. Ketones are the product of fatty acid oxidation. In kids with type 1 diabetes and in some individuals with type 2 diabetes, so type 1 diabetes is autoimmune diabetes, what we typically think of as out of the textbook would be a little kid whose immune system destroys the pancreas and they need insulin all the time. We worry about something called diabetic ketoacidosis. So that happens when there's not enough insulin around and the body breaks down fat and muscle and produces ketones. And ketones are an acid. So if they build up and build up and build up, they make people feel quite sick. So in people with mitochondrial forms of diabetes, they don't always make ketones as a result of their diabetes, but sometimes they do. So that can be a helpful thing to know about yourself if you have mitochondrial disease and diabetes, whether or not you tend to make ketones. And checking that in addition to checking blood sugar can help with optimal management. So with respect to what medicines are the right ones to use, there are a lot of medicines that get used to treat diabetes. I think, and they're beyond the scope of this talk, we could really do a whole talk on the medical management of mitochondrial forms of diabetes, as well as nutrition, as well as exercise. But I think with respect to medications, I think it's just really important that as you go through the list of options with your doctor, you consider the potential off-target effects. So there are some medications that are less safe to use, for example, in the setting of kidney dysfunction or in the setting of liver dysfunction, or interact with other medicines. So just being very thoughtful about those different options is really important. Insulin often is an option and often works well in relatively modest doses. So insulin has the benefit of also decreasing catabolism. So you guys have maybe heard this word, but catabolism is essentially the body's starvation mode where it's breaking down muscles and fat. And usually folks with mitochondrial disease don't feel so well in that setting. And insulin along with fuel is one way to reverse catabolism. So insulin is the mainstay of therapy, often in younger individuals as well. And I put a resource down here. So the American Diabetes Association website has a curated list of, I think, of the 16 approved pharmacologic therapies for diabetes that you can go through in detail, and has some really nice patient resources as well. So switching gears from sugar to stress, the adrenal gland. So cortisol production, cortisol is the main hormone we think about as being an adrenal hormone, is regulated by an axis that we call hypothalamic pituitary adrenal. So hypothalamus and pituitary are in the brain, and they make hormones that control the two triangle-shaped glands here, the adrenals, that then make cortisol. So one thing that I tell folks, and they're often struck, but this is where my interest comes from, is that mitochondria are critical for the synthesis of steroid hormones, of which many are steroid hormones. So it is not surprising that multiple forms of mitochondrial disorders come with problems in steroid hormone synthesis or function. So adrenal insufficiency is the condition of not having enough adrenal hormones. So the way this manifests can be low blood sugar. So one of the jobs of cortisol is to keep the, is there a question in the back?
I have a quick question. I had never heard of adrenal crisis or adrenal insufficiency until I had it. And it scared me because I was nearly comatose by the time I got to the hospital and possibly nonsense. How do you prepare to go to, like, how do you prepare a hospital to know that's why you're going in if you're not conscious or not able to communicate?
So that sounds like a really scary experience. I'm sorry that happened to you. But I imagine other folks will learn from your experience that this exists, right? So the point that the young woman in the back is making about adrenal insufficiency and being aware of it. So the biggest risk related to adrenal insufficiency is never thinking of it. So it happens if someone is very ill or shows up, and at our hospital we think about it all the time, and so that's less of a concern. But this is part of why you guys educate yourselves, and why our emergency letters for our patients with mitochondrial disease. There are some forms of mitochondrial disorders that this is more likely to occur, some that it's less likely to occur, but we include a line at the bottom that, even if folks do not have a high-risk condition, that this is something that can occur in mitochondrial disorders if you have, persistent and unexplained low blood pressures, low blood sugars, low sodium levels, the person is critically ill and not responding. This is something that should be on your list of possibilities for why they're behaving that way. For people who have adrenal insufficiency, we develop an emergency plan and a medical alert bracelet. What a good question. So she's bringing up a great question, and I think I have a couple slides that will speak to that. I'm noticing other people kind of nodding, or it seems like some of this is resonating with them as well. But let me get a few more slides into it. Actually, a few more slides on adrenals because it comes up so often. And by the question session, if I haven't covered what you're interested in, we can go over it for sure. So for folks who are less familiar, it sounds like some folks are more familiar. Adrenal production of cortisol, of this hormone, has what we call circadian, just a little background so you guys can feel prepared as we go through it, has what we call circadian fluctuation. So this is I present it because it's difficult. It can make a level difficult to measure and interpret, right? So this is the time of day here on the x-axis of this graph, and this black is when most people are sleeping. So I think this is presented in a funny way because here's 8 o'clock in the morning, right? So the highest level of cortisol typically is at 8 in the morning, and it's usually low at midnight, right? And then it comes kind of down, and then lower in the afternoon, and then down into the evening. So it poses a problem if you're in the clinic at like 4 p.m. and we want to go send you for a level. Well, it's going to be low, but that's not really the most meaningful time to assess it, right? Often we do our screening at 8 o'clock in the morning. Excuse me. And then with respect to adrenal replacement therapy for people who are deficient, for most people who have adrenal insufficiency, the most important time to be aware of it is during times of stress. And we call the high dose or higher dose of steroids that we use in physiologic stress as a stress dose. And I should mention stress, in our kind of common parlance, stress often means like emotional stress or really difficult day. What we mean here is very high fever, very significant illness, operation. So the psychological piece we can kind of set aside and discuss another day because it's really interesting. But what we mean here really is the very critical illness. And so people need higher doses then. Some people, not everyone, it depends on the condition, need a little bit of cortisol every day or steroids, so physiologic replacement. And I've listed some doses that get used in adults just to give you some context. Some people would use kind of prednisone, 5 milligrams as a physiologic replacement, whereas 20 milligrams might be a stress dose. So the stress dose is much higher than a replacement. And the formulation and the doses are something that we discuss a lot. So management of adrenal insufficiency, this picture is to remind me to teach you. This is one section of a part of the adrenal gland, and this is here to remind you that the adrenal gland makes a few different kinds of hormones. So cortisol is a glucocorticoid, and so that's the one we've been talking about mostly. That's the one that's most affected and gets most attention. But it also makes a mineralocorticoid. This controls salt and water balance. So medicines related to that might include fludrocortisone or Florinef, people are familiar with. The adrenal gland also makes a weak androgen, a male-type hormone called DHEAS. And the innermost part of the adrenal gland, the adrenal medulla, makes catecholamines. That's like adrenaline. That's our fight or flight response. And this is something that's important to think about because if the rest of these are affected, in some cases, catecholamines are affected to some extent as well. All right, so those are all the hormones in the adrenal. Screening for adrenal insufficiency, we often start with an 8 a.m. ACTH and cortisol, and sometimes we look at the other hormones. So depending on the clinical picture, we would often focus on cortisol, but in some settings we might look at other hormones as well. And the reason for that 8 a.m. has to do with that circadian fluctuation I mentioned, because we're looking for the capacity of the gland to achieve that morning rise. There is something called provocative testing, because we want to know not only what do people do day to day at 8 a.m., but we also want to know what would they do if, God forbid, they were very ill. And that's where provocative testing comes in. Usually that means coming into day hospital or the office for the better part of a morning, getting an IV placed, getting hormones through the IV that typically cause the cortisol level to go up, and then see, does the cortisol level go up the way it should? And that's more involved. And then decisions around replacement, right? So this is what came up, do you need glucocorticoid only? Do you need glucocorticoid and mineralocorticoid? What kind, like hydrocortisone, prednisone, decadron, like which formulation is right for you? Do you need some every day, or do you need only when you're stressed or sick? Or actually, do you need them not at all, but maybe just keep it in the back of your mind if this child is very, very ill, because perhaps that could occur. There are lots and lots of adverse effects to too much steroid, right? So this is, we tend to, if we're concerned and we think someone's critically ill, we tend to err on the side of giving it, but doing that too much can have a downside. And one teaching point from here I should mention, the best way to articulate this is challenging, but often people, when they get stress dose steroids, feel transiently better. And that does not always mean that adrenal insufficiency was the problem, which can make it really tricky. Like steroids are our body's way of like fighting back and feeling better transiently. But if, for example, I got appendicitis, right? I don't have a mitochondrial problem. If I got appendicitis and I got steroids, I might transiently feel better, but I would still have appendicitis and the steroids would not fix that, right? And I don't have adrenal insufficiency. So that is what can make it tricky, is that sometimes treating, feeling better after steroids means the person has adrenal insufficiency. Sometimes feeling better after steroids just means feeling better after steroids, and some other problem is being masked or treated by something else. Does that make sense? So that's a tricky one, because often we want to try to gauge someone's response to therapy as in kind of a diagnostic maneuver, but it doesn't always work. And we have to be mindful that there can be lots of bad effects, particularly to high doses of steroids. So this is Cushing's. You guys may have heard of that. Cushing's is the other side. So adrenal insufficiency, too little. Cushing's, too much of adrenal hormones. So adrenal excess can be iatrogenic, which just means the doctor said it, too much steroids. Steroids can get used in very high doses for anti-inflammatory purposes, and they can work quite well, but then they have downsides. So I take care of kids, and this is from an NIH-supported Cushing's website. You can see what happens to these children when they got Cushing's by comparing photos before and after. Excess weight gain, kind of plethoric faces. Blood sugar can go up, bones can get weaker, other hormone systems can be adversely affected. So really high doses of steroids are not good. Other forms of steroids can exist that are not iatrogenic, where the body itself makes too much steroid. Those are incredibly rare, but they do exist. All right, so leaving steroids for a moment, calcium and bone. So calcium and bone are other areas that are really important. Calcium levels in the blood are regulated by the parathyroid glands. So they're represented on this diagram by these 4 black dots, and they should be 4 black dots that are right in the neck. They're called parathyroid because they're right next to the thyroid, but they just live there. They're not like related to each other. But the parathyroids are what control the calcium levels in the body. And some people with mitochondrial problems have a problem where they make too little PTH, or they have too little magnesium, which can affect how PTH works. PTH is the abbreviation for parathyroid. And then if their calcium levels get too low, they can become sick from that. So problems from low calcium levels can be quite serious and sometimes life-threatening. So muscle weakness and if very significant abnormal heart rhythms and seizures can come from low calcium levels. So there are replacement therapies if low PTH exists. So that's PTH-related problems. Bone is a whole nother area of interest for us. So osteoporosis, and this nomenclature, fracture syndrome, is something that's been really newly introduced, but I kind of like, because weak bones is one thing, but the real problem comes from breaks, comes from fractures. So clinically, bone mineral density is assessed using something called a DEXA scan. I don't know if folks are familiar with that, dual energy X-ray absorptiometry. The way it happens is actually one of the easiest tests we do. People just lie on a table. It's a very low dose of X-ray, and it measures bone density. Now, the other tools we use that have subsequently built on DEXA that have told us that the bone mineral density isn't the only dimension to bone quality, right? DEXA can look okay, but bones can still be at risk. And again, bone breaking is really what we worry about, and the risk for fracture is multifactorial. It's all sorts of factors that contribute. So there's this tool called the FRAX tool that gets used clinically to assess fracture risk. It will perform okay, but not perfectly in people with mitochondrial disorders, right? Because it doesn't evaluate the full scope of risk factors that folks might experience, but it certainly is a start. One teaching point, and I'll get to more on bone health in a minute, but from my own clinical practice is to consider atypical fractures when new symptoms happen. So I cared for a young man who was helping to move Christmas decorations at the holidays, and he picked up a box of ornaments and moved it to another place, and he had osteoporosis of the spine, and literally that movement was sufficient to produce a pathologic fracture of his vertebra. So he had lower back pain, but the family didn't consider that he might have broken a bone for a while because he didn't fall. I mean, turning with the box of Christmas ornaments didn't seem like something that should produce a break. So he was dealing with this back pain for a bit before he sought medical attention. So, I mention his story because I say we call this an atypical fracture or pathologic fracture. In other words, in someone with typical bone strength, a movement like that wouldn't be expected to cause a fracture, but in this young man it did because he had a metabolic disorder along with osteoporosis. So if there's a new symptom present, gosh, that, as clinicians, we think that should be on our list of things to investigate because it can certainly happen. This is another paper we published recently. Shifa is a medical student with an interest in mitochondrial diseases, and she quantified in the cohort of around 80 individuals that we have at CHOP with mitochondrial disorders with molecular diagnoses, the risk factors for poor bone health. So the FRAX tool captures a number of them, but she went through, and this isn't even everything, right? But chronic illnesses, immobility, malnutrition, acidosis, diabetes, kidney problems, vitamin D, antiepileptics, endocrine problems. So those can add up quite quickly. So poor bone health in this population is a really significant problem and something we need to learn more about how to improve. So what can we do? We still go back to calcium and vitamin D. I'm including these references for you of typical recommended daily intakes of calcium and vitamin D. This is in case folks aren't familiar with how to read a nutrition label on calcium. I know this is a sophisticated group, but when you have this nutrition facts label that you're used to seeing, the calcium here has 30%, and the RDA, the recommended daily allowance on which the label is based, is 1,000 milligrams of elemental calcium. So this has 30 times 10, 300 milligrams of elemental calcium in it. So for folks who are using guidance to try to get up to the total amount that they should eat, this is one way of looking at the label. Folks have asked about about medicines to treat low bone mineral density. I really like the Hormone Health Network website. I've included the link here on hormones and bones, and summarizes the medicines that we tend to use really nicely because it's beyond the scope of what we have time for right now. But there's classes of medicines called bisphosphonates. That's the alendronate, pamidronate, zolendronate. Those are anti-resorptive medicines, so they prevent bone breakdown that can reduce bone mineral density. Denosumab works by a different mechanism, is an anti-resorptive. Teriparatide is one of the newer medicines that works by trying to build the bone. The selection of which medicine to use really depends on who you are and, again, the concurrent risks of these other therapies. I've also, this doesn't reproduce quite as well here, but summarized the Hormone Health Network. This is all common sense. You guys know this already. But calcium and vitamin D, weight-bearing exercise, avoiding smoking, avoiding excess alcohol. But weight-bearing exercise helps not really only just to strengthen the bones per se, but to make the muscles stronger, improve balance, and avoid falls, because falls is what leads to fractures. Someone had a question.
We were told about the seizure drugs causing bone loss, so we supplemented with calcium. And now the GI doc has got some concerns because the GERD drugs can be leaching out the calcium as well. Is that true for all GERD drugs, or?
Great question. So I think you're probably thinking about the PPIs, the proton pump inhibitors that can affect bone health. I would guess that's what what's your EGI doctor saying? Yeah, those are proton pump inhibitors. Mm-hmm. So it's really difficult because there's a lot of push-pull, right? You need one medicine for something, but then it can have a side effect that can affect something else. So in the setting where is there someone at risk for poor bone health and they're on antiepileptic medicines that can affect vitamin D metabolism and PPIs whose effects on bone we don't entirely understand yet, but changing the acid base in the stomach can affect calcium absorption. An endocrine bone health specialist can help work with you to, first of all, measure vitamin D levels and make sure that you've got vitamin D where you need to be. And then sometimes it's a matter of spacing out calcium from PPIs to make sure that we're absorbing it the way you need to. We also sometimes track urine calcium to creatinine ratios to see, is this person getting enough? I thought where you were going was, and then we ended up with too much, because that can happen too, and we want to avoid the other extreme as well of getting too much calcium. So in people who are very at risk, following levels can be one way to minimize the risk or to try to kind of strike that really challenging balance.
Okay, thank you.
Sure. So thyroid, we're getting through all these different axes. So thyroid people are probably familiar with because thyroid dysfunction is pretty common in the general population as well. Symptoms, however, incredibly nonspecific, right? It's very difficult. Fatigue, temperature intolerance, change in bowel habits. These have lots of other causes besides thyroid dysfunction. The way we assess thyroid function in the lab, 2 sets of hormones. One set of, I really like this diagram from the American Thyroid Association because it shows where we get our sets of hormones. So one set of hormones is from the pituitary. That's thyroid-stimulating hormone, or TSH. And another whole alphabet soup of hormones comes from the thyroid itself. Those are the different forms of thyroid hormone. And I like this table also because it shows what the levels tend to be in some of the thyroid problems that we see most often. Of course, there's normal, where the TSH and the hormone levels are normal. What we see mostly is questions for hypothyroidism, so too little thyroid hormone. In that setting, often the TSH will be high. That's because the pituitary is responding to an underactive thyroid by trying to stimulating it to work harder, but it just won't. Sometimes, though, the pituitary doesn't respond in the normal way, and the level of thyroid hormone is low, and the level of TSH is low. Another problem we see sometimes something called hyperthyroidism, where there's too much thyroid hormone being made by the gland. That's less common. So if thyroid hormone levels are low, which is something we see often, replacing that hormone can be something we do. Other considerations that are important for you to know is that thyroid levels checked in the time of illness or stress may not reflect the thyroid function when people are well. So those hormones can really be thrown into disarray. And so you should just be thoughtful about replacing thyroid hormone when someone is ill, because sometimes the levels really aren't reflecting the thyroid status. Okay, so that was really quick on thyroid. Sex steroids, estrogen, testosterone. Hormone Health Network, again, has some really interesting symptom assessment tools for hypogonadism. So that would be too little estrogen or too little testosterone, which are the problems we see most often. Symptoms obviously depend on whether you're a man or a woman, but sexual function and bone health problems can be common to both. FSH and LH are the pituitary hormones that control sex steroid function. E2 stands for estradiol, that's the estrogen, the female hormone, and testosterone is the male hormone, that's our starting place. But what we do about hypogonadism or too little hormone really depends on the etiology, on the cause. First we try to figure out what's going on, what could the cause be. But then there are replacement strategies for both estrogen and testosterone that we can use to try to address concerns about sexual function and bone health. There are lots of considerations with respect to adverse effects of hormone therapy. Again, beyond the scope of this talk, for women, estradiol and blood clots is something that's really comes up often. But worth thinking about for new symptoms, and worth thinking about for women in particular, evaluating menstrual irregularities, because there can be other causes besides hypogonadism that can lead to those. Whoa, so this is not a hormone problem. This is to remind me to check the time, because this is around halfway through, but I think I can go more concisely through the rest. It's Canada Day. Happy Canada Day. I'm originally from Canada. This moose we met not in Canada, but in Colorado. And it was not me who took the picture. It was my husband who kept watching the moose instead of walk away, which would have been smarter. Okay, so that's halfway through. And we'll just kind of hustle up because I see I'm looking at the time. We're running just a smidge behind. But I think we got through some questions on the way, so that's okay. So growth hormone, why are we thinking about growth hormone? Children with mitochondrial disease can be short. Folks know that. This can happen even if their weight is maintained. So some kids really struggle with keeping their weight up. This is a neat paper from the UK group. This is BMI and this is height, and this is showing the kids being short. But they're short, even later life, maybe their body mass index is lower, but even in earlier life when their body mass index is okay, they can be short. And sometimes that's from growth hormone deficiency. And growth hormone is really one of the hormones that can also affect mitochondrial function. So it's been shown to increase ATP synthesis in muscle by biopsy or by non-invasive imaging. Growth hormone releasing hormone is one hormone upstream of growth hormone in the hypothalamus. It gets used for HIV lipodystrophy, which is a form of secondary mitochondrial dysfunction. So growth hormone has effects that are beyond growth, so important for muscle mass and for bone health and for energy in particular. Adults make less growth hormone than kids because kids are growing, that kind of makes sense, but they don't make none. So adult growth hormone deficiency does exist. This is the Magic Foundation, is a different website, but I like their adult growth hormone deficiency information better than some others. Patterns that might suggest this entity, of course, if you had growth hormone deficiency as a child, it's worth revisiting what your growth hormone status is as an adult. Hypoglycemia, growth hormone can be implicated in maintaining blood sugar, fatigue, decreased muscle mass or bone health. Of course, these are incredibly common in the population of individuals with mitochondrial disorders. It doesn't mean that everyone has growth hormone deficiency, but it's certainly on the list of possibilities. Growth hormone is made in pulses overnight. So assessing the growth hormone status is pretty tricky because what we do in a research setting is bring people in and measure periodically all night long, and that's not practical. So there are growth factors that we check. They're called IGF-1 and IGF-BP3. There are also some provocative tests, similar to the adrenal studies, where we bring folks in and give them hormones and assess their response in some people to see whether or not they might need growth hormone. So growth hormone, of course, is what is used for growth hormone deficiency. Growth hormone releasing hormone I just mentioned here as something for future research that we're thinking about. Growth hormone has a number of side effects, though. Particularly, it can make the blood sugars go up. So if you have hypoglycemia, that's a good thing. If you tend towards diabetes, that might be less of a good thing. There's other side effects with growth hormone as well. So like most endocrine dysfunction, if there's true deficiency, replacing it really helps. If there's really not, then it sometimes can do more harm than good. So dyslipidemia, cholesterol problems. One thing we tend to see more often is high triglycerides. So triglycerides are one part of the cholesterol panel that we see. Triglycerides can be important for cardiovascular risk, but acutely, if the triglyceride levels get really high, then they can put people at risk for something called pancreatitis. And pancreatitis, when the pancreas gets inflamed, people can get quite sick from pancreatitis. So that's only if they were very, very high, but we do pay attention to them for that reason, because in some people, they do go in that direction. Drugs already in clinical use for this problem deserve more study. I pulled this figure from a paper from some of our colleagues at CHOP. The details here are less important, except for to know that these are mitochondrial function assays, where cells from individuals with mitochondrial disorders were given nicotinic acid, which is one drug that gets used for dyslipidemia, and that tended to improve mitochondrial function, both routine and maximal function, going from this black bar to this light gray bar. And that to me is relevant because if there is an option to treat a problem that someone has with a medicine that may help their underlying condition, that seems like the better course than, I imagine most of this group has been cautioned against the use of statins because of the myopathy that can occur, right? So if you're choosing from among therapies, it kind of makes sense to try to tailor your choice to something that might help your underlying condition instead of hurt it, even though for the broad scope of the population, another drug might be first line. So lipids, how do you assess them? Lipid profile. So, my patients who do not fast overnight, I do not have them fast for lipid profile because I don't want to do more harm than good by assessing this level, right? So we kind of take people where they are. We can often learn a lot even from a non-fasting specimen. Nutritional and lifestyle changes can help for triglycerides. I've listed some of the medicines here that can be helpful. There are known adverse effects with each of these medicines, and www.heart.org has a nice chart of the different medicines for high triglycerides and what their side effects are for folks' reference. So excess weight gain, this I did not include the first time I gave this talk, but it's become something that we've learned a lot more about. So by some estimates, this is a paper from the UK, but this is a paper from our group, and we found similar numbers in adults with mitochondrial diseases that around 50% are overweight and nearly 20% are obese. And this, from the UK group, this is on the x-axis here, clinical phenotype, so the NAMDC score, or the NAMDC score rather, and number of steps walked per day. And you can't see this caption under here, but this is the chicken and egg problem, right? Are people feeling less well because they're less able to walk? Are they less able to walk and so they're feeling less well? And probably both of those things are true. But easy weight gain is something that seems to come along with mitochondrial disorders, whether intrinsic to the condition or part of the general challenge in our society, or some combination of both, which I think is likely true. Ectopic lipid is something we talk about a lot. So this is a New Yorker cartoon, and I'll read it to you because I really like it. I found it, and actually a patient brought it to me because we study ectopic fat. So ectopic fat means fat where it shouldn't be. Fat is very helpful. It does a lot of great things for us. But sometimes fat is where it shouldn't be. This says seasonal fat, alluvial fat, glacial fat, primordial fat. So this is the cartoonist interpretation, but it's not too far afield. Sometimes fat goes where it shouldn't, and then it causes problems. So why does this happen? So some folks with mitochondrial problems have decreased fatty acid oxidation as part of their condition, so fats aren't burned the way they should be. Sometimes fat goes to places where it shouldn't because the subcutaneous compartment, that's considered the more healthful place, so like places you can pinch. Fat goes to the organs if those other areas are full or those other areas can't hold it. If there's more fatty acid in circulation, replacement of healthy tissue with fat can occur in mitochondrial diseases. I'll show you that. And so why do we care about that? Well, incompletely metabolized lipids, so those fats that are where they shouldn't be, can contribute to diseases. In particular, from my end, we think that they may contribute to diabetes. So this is we do a lot of metabolic imaging studies, and this is from a gentleman in his late 50s with CPEO plus from a twinkle mutation. This is we do an MRI of muscle to look at oxphos, at mitochondrial capacity, but these are just anatomic images, so just a picture of the image. So this is the lower leg, this is the shin bone on each leg, right? And this is the calf, and this is the fibula. So you can see this is muscle tissue, right? But then in this medial part of the calf, this middle part of the calf is almost entirely replaced by fat. And this is something that we see, and we can imagine this. And we know from imaging that this muscle doesn't work the way it should to help people walk or do exercise, and it certainly doesn't help with respect to their diabetes risk. So we're learning more about why this happens, but we know that it does. So I'm not going to give you a magic bullet here, and no one was expecting one. Identify and treat reversible causes, right? So there are lots of potential contributing factors, and addressing them is important. I hope folks were able to hear Mark Tarnopolsky's talk on exercise, because I agree with him a lot. It's so difficult for many people, but for those who are able to find an exercise regimen that works for them, it's incredible. And so that would be my starting place, is to really focus on that first. I realize it's much easier said than done. But each person is quite different, so a strategy that works for one person may not work for someone else, and I know you guys know that better. Oh, supplements. I think you guys probably talked about this, but it hasn't gotten as much attention at this conference, so I'm just bringing it up again. So we have this working group, Nutritional Interventions in Primary Mitochondrial Disease, that got started from this conference in 2014 at NIH. Folks probably know that supplements are not manufactured to the same standards of drugs. So sometimes they don't contain what they're supposed to. We have this example from citrulline deficiency that I won't go into. But you can speak with your physicians or pharmacists about, and I ask our pharmacists what supplement formulations are on the hospital formulary. This seems kind of off topic as I'm saying it, but whenever I see a patient and I'm wondering what's going on with their hormones, what else they're taking is really important to me. So trying to make sure that any supplements they're taking are as true to what they're supposed to contain is really important. I have a few more minutes left. So I was going to go into some of our hospitalizations data, but I think I'll skip that in favor of just going through research really quickly. So summary-wise, this is like whirlwind tour of endocrine, right? All the hormones, everything you ever wanted to know. You're ready to be an endocrinologist. I am going to just show you a couple of research studies in the few minutes that remain, really because I want to be able to thank some of the folks who participated in the study, who may be here. So we have a few studies. This one is a study of low versus high glycemic index nutrition. It was a randomized double-blind crossover study of several test meals, and we looked at different outcomes. That study is finished, and really our UMDF was instrumental in recruiting for our study, and folks participated, which we really appreciate. And we had a poster this week, and a manuscript is coming out too, so thank you for those of you who are in that. This is a protocol using an MRI-based strategy to quantify muscle creatine and muscle oxphos capacity. And we had folks from UMDF and NAMDC in that study also that was recently published. So we're really excited about that as another way to understand how the muscle mitochondrial function is working. And this is another study we have going on right now, building on that, of looking at how the muscles, how muscle mitochondria are working, and looking at how the body handles glucose and lipid. So that's an ongoing study that we're recruiting for now. So I wanted to thank all of the folks who participated in that and the UMDF for allowing us to recruit. And this is all of our research and our clinical team, and I won't go through all that, but that's it. Sorry for that really fast presentation, guys. So I think we have 5 minutes, so if anyone has remaining questions, I'll take them. I see one in the front.
So I have diabetes, and I don't have type 2, and I tested negative for type 1. I don't have any antibodies. So how do I get my endocrinologist to either test or give me a diagnosis of mitochondrial diabetes?
So the question that came from the front was from a woman who says she has diabetes, not type 2, and has no antibodies. Anti-pancreatic antibodies are the tests that we usually do to look for evidence of autoimmunity. And if 4 out of 4 of those are negative, it doesn't rule out the possibility of autoimmunity, right? Like the pancreas is really difficult to biopsy. We don't do it for a lot of good reasons. So how do we get the diagnosis? Well, a couple things. One is there are genetic tests available for monogenic forms of diabetes and for mitochondrial disorders. So that testing is not trivial to pursue, but certainly is worth it. And we do pursue those routinely for people who have a diagnosis of diabetes that clinically does not seem typical of either type 1 or type 2, or lab-wise isn't. Maybe I'll ask as a follow-up the utility of having that diagnosis, like what, some people have lots of different reasons of wanting that diagnosis. Sometimes it can help with respect to management. Sometimes it's an insurance consideration. Sometimes it's, I can't get a pump unless I have a particular diagnosis. So I'm curious, do you have a thought?
When I go to different doctors and they ask me, well, do you have type 1 or type 2? I don't know.
So what she's saying is it's difficult when you go to a doctor and like what do you have? And so on the one hand, I'm glad that you say that, because sometimes if you say if you have mitochondrial disorder and you say type 1 or you say type 2, then people turn off their brains and stop thinking. And if you come in sick, they don't think, oh, this person could be having a metabolic stroke because she has diabetes that's not type 1 or not type 2, and I wonder if that's really a mitochondrial disorder, right? On the other hand, not having a diagnosis can be stressful, and also can get in the way of knowing how to screen you optimally for other related health problems. So in my view, usually genetic testing is the next step for monogenic and mitochondrial forms of diabetes, to try to at least look for what's known. And because those there's some monogenic forms of diabetes that have specific different medication therapies, so there's sometimes very specific treatment indications. So usually insurance-wise, we have success getting coverage for that, at least that initial step in testing.
Okay. Thank you.
Yep. I'm going to go to the back of the room, to the woman in the green shirt. Lots of people in green shirts, but her.
I was just wondering, with respect to cortisol and adrenal issues, at one point they were doing adrenal testing for me, but the cortisol levels always came back high, but they were still supplementing with cortisol, so I guess I'm kind of confused as to why.
I find that a little confusing too, without knowing all the details. One thing for young women to remember is that birth control pills, so exogenous estrogen, will increase the amount of cortisol binding globulin, and so will make the total cortisol level look higher. So a woman who's on birth control pills needs to have her cortisol levels checked and looked at in a special way. So that's one consideration. Sometimes you think about like a pre-stimulation cortisol versus a post-stimulation cortisol. So people may be reacting to the difference between the two. That's one thing I can think of. But yeah, usually it's the replacement strategies are because the cortisol didn't go up enough or wasn't high enough. Does that make sense? Your intuition there seems right.
Okay.
It's worth kind of getting to an understanding of what the thinking is. I agree with you. And then this woman right here.
I have a question about back on the statin issue. So if you have a high statin levels and stuff, and then I have cardiac issues and I have to keep mine even lower than used, and I was okay, but now I can't take statins because of all the muscle problems from it. So what kinds of things do you recommend to those people that can't take statins but need to keep their levels low and they're high?
Yeah, it's a great question. So we should talk afterwards because there's a whole, like, and especially some recently introduced medicines that may be helpful for you, like ezetimibe is one. Yeah, and then there's PCSK9. You know, so I do this less often because we have a terrific adult lipid heart clinic that we work with, but statins are for sure not the only option. And so that's why the www.heart.org has a nice chart for us of some of the non-statin alternatives that you can use. But ezetimibe and PCSK9 inhibitors.
What's the first one?
Oh, I'll write it for you.
Okay.
Yeah.
All right, thank you.
How about the other woman there in the green? We'll go with green again. You, yeah. Or that's the blanket, I guess. It's nice.
I don't know if I can switch about it. I've been told that metformin is myotoxic to diabetic AD. Was there some other drug that's without going nutritional straight to insulin? Is there something else that can be used instead of metformin?
What a good question. So we get the question on metformin. The question is, is metformin bad? And if so, what else should be used before going straight to insulin? So metformin, the caution there comes from the risk for lactic acidosis. So if folks already have a high lactate or at risk for high lactate, or their diagnosis makes them at risk for a high lactate, or particularly if they have liver involvement in their condition, metformin is relatively contraindicated. You know, in some select patients who don't have other good alternatives, we sometimes consider trying it carefully, sometimes, but rarely. GLP-1 agonists, so the liraglutides, sitagliptin, those types of GLP-1 kind of axis-modifying therapies, those are newer, so there's less accumulated experience in mitochondrial disorders, but there's some suggestion that they may protect the beta cell. So those are things we sometimes think about before insulin. It really depends on the person too, on like whether or not they're ketotic and kind of how acute their needs are for insulin replacement, like how high their A1C, et cetera, that kind of thing. There's someone right behind you.
So following up on that question, does it have to do with dosage of the metformin that makes it, I guess, shaky or
risky? You know, we are so hesitant about that risk of lactic acidosis that we don't have a huge cumulative experience of metformin use. But you know, we take care of people with Friedreich ataxia-related diabetes, for example, and Friedreich ataxia is a molecular lesion that affects the mitochondria as well, but the liver is less affected in those individuals. And many of those folks have been put on metformin and seem to do fine. A lot of people don't tolerate higher doses of metformin even without known mitochondrial problems, like the GI distress is often really limiting for a lot of people. So it seems intuitive that maybe the dose would matter, but there's molecular evidence that, that metformin inhibits complex 1 of the respiratory chain. And so if someone already has, you know, mitochondrial-related dysfunction, then it says, well, gee, we should maybe be very thoughtful about inhibiting it further, right? Because that could produce more problems. And whether or not that's dose-dependent is just difficult to assess because it hasn't been studied very well.
Thank you.
How about up here?
I had a question. My daughter was on growth hormone as a child and came off as a teenager, but she's in her early 20s and she's recently, the past 2 or 3 years, developed amenorrhea. Her periods stopped. When she was on before, it was very hard to get it through as an adult. I was wondering if that is possibly related.
What a good question. So the question is, someone who previously had growth hormone deficiency and came off and now is having amenorrhea, could those two be related? So growth hormone deficiency doesn't typically cause amenorrhea per se. However, geography is important in real estate and in pituitary hormones. So if one pituitary hormone is affected, like growth hormone, the neighboring pituitary hormones that can affect the menstrual function may also be affected. So in that way, I wonder about a connection. So we have successfully gotten growth hormone reapproved for adults, often after having to repeat provocative testing though. Like sometimes it's not enough to have done it in childhood and continue, but to repeat it. But certainly amenorrhea in a person who has a history of having had growth hormone deficiency deserves a pituitary evaluation as kind of a first step. I see her coming up here because it's past time, but I really want to thank everyone because I hope I said at the beginning I learned so much from all of you and your questions to prepare for next steps. So thank you guys very much. We really appreciate it.